Hello friends. Now looking up the recent trend, they are asking you more and more clinical scenarios, and they have already given as proposed for the next 2022 paper that there will be 60% questions will be clinical scenarios, comprehension and analytical kind of questions. So that means more and more integrated questions will be coming, and you have lot of ocular manifestations in so many chronic systemic diseases. So keeping that in mind, I am trying to come up with a series where I'll be talking about the ocular, not only just the name but also in detail what will be the ocular manifestations of that particular systemic disease, so that when you get a question which is integrating your medicine or your infectious diseases kind of things along with the ophthalmology, you are able to comprehend. Now this depends upon them when they are integrating the ophthalmology and medicine per se. Are they asking mainly the question related to medicine aspect, the clinical features aspect, the ocular features aspect, the investigatory part, the diagnostic part, the consequence or the treatment. So our goal is completing that topic as a whole. So today I have taken a very important topic, and that is the Henson's disease or the leprosy. So let's see the eye in leprosy. Now, why I did chose this one? Because it's very difficult for a blind man to carry out his routine activities, we know, but it's even more tragic when this blind man could not rely on the sensations of his hand and feet. I think that is the biggest asset of a person who cannot see. I'm saying this because I personally don't like to use the word blind, because for us they are blind, but actually they are not. They are seeing with the eyes of their hands. They have that sensations. They are seeing with the smell of the nose. So if they will really become handicapped if they are not able to rely even on the sensations of their hand and feet for their daily activities. And so the preservation of the vision is a very important aspect in the patients who are affected with the Henson's disease. Now, in the initial stages, the person is usually asymptomatic for the ocular manifestations, and this actually calls for a very important thing, the importance of the routine eye care in the Henson's disease. And I think this is a very enlightening, because as an ophthalmologist, I am getting the cases of the ocular complications in those patients who are having the systemic diseases, but when they are actually sent for the physician's referral, okay, at that time these things are not the first to take the priority, and that is why they are often neglected. So now there is a big time that we will have to even tell that the physicians should also send for the referral from the very first day. I mean, like, the treatment should go hand in hand and not one after the other, because in the Indian scenario somewhere it is kept in their mind that first they'll go for the medicine, and when everything is fine then they'll come to the specialities. So it should not be there, because there are definitely certain things that could be taken care of at their best only when the patient is coming to us in the early stages. And if the patient is coming in the fibrous stage, when the scarring is already there, obviously we cannot do wonders there. Now, the ocular involvement in the leprosy is up to 70 to 75%. I think that is a big figure and we cannot be careless about it. especially when the severe ocular symptoms occurs in up to 50% of the patients, and about 0.5% of these patients are losing their vision, becoming blind. And the eyeball along with the adnexa both are involved. And lastly, even the multi-drug therapy does not guarantee withholding, does not guarantee, is important, it does not guarantee withholding the ocular complications. So don't wait for the complications. Okay. Now, what will be our main objectives here? The first important thing in which we are interested is what are the different modes of infection. So, we are actually starting from what you can say from the primordial care. So, we'll start from the primordial care, then primary, secondary, tertiary. Okay, don't send the patient where we can only do the tertiary care. So, that is a very important aspect. You know, 10% of the questions in every subject will be from public health. So, I'm trying to deal with the public health of ophthalmology also. Then, what are the parts of the eye involved? What will be the complications, history and examination along with the management. So, we will be doing all these things one by one. Now, let's start with the modes of infection. So, how this Mycobacterium leprae can actually enter the eye. So, first important thing is the direct invasion of this bacteria into the eye and the surrounding tissues. Second important thing, there can be inflammatory lesions. So, what happens? The sensitization of the ocular tissues to this antigens can take place, and there will be formation of what? There will be intravascular immune complexes. See, this is pathology with ophthalmology. So, you have direct invasion, you have inflammatory lesions, and you also know that it is a granulomatous disease. Leprosy is a granulomatous disease. So, there can be granulomatous infiltration of these nerves also. Now, along with this, there will also be involvement of the contiguous structures. So, that's why I told you that along with the eye, adnexa will also be involved. We have the involvement, a very important thing. We have the involvement of eyebrows, eyelids, lid, glands, lacrimal drainage system, all these things. So, I can say that there is so much of elaborate involvement of the eye structures by this Mycobacterium leprae, and not only this, even the direct infection, secondary infections can also play a major role here. Okay, now let's talk about the direct involvement. Now, direct involvement of the bacilli is taking place through the blood stream. So, these can be your potential MCQs also, that it can be taking place through the blood stream. Okay. Now, which of the segment is involved more? So, anterior compartment is involved more than the posterior. They are saying compartment, so that is same as the segment. So, what is happening? Mycobacterium leprae is actually entering the eye. So, first is this, then it is going through the ciliary body, then it is going through the autonomic nerves and ultimately invading the iris. And remember, the invasion of this iris is one of the important consequences in the Henson's disease. And if you remember, we have got the iris pearls, something called as iris pearls that we get in cases of this leprosy. So, I will be talking about that also, where they hide from the effective treatment, from the effect of treatment. So, they are like cockroaches. They are going and hiding, and when they are hiding, what is present inside the iris pearls? That is why inside the iris pearls are actually present the bacteria, Mycobacterium leprae, because they are hiding there. I'll be showing you, they are in the periphery of the iris. Small nodules, whitish color nodules are formed. They are very, very pathognomic of this leprosy, right? Okay, now we have got two spectrums in this. One is your tuberculoid spectrum, and on the other hand we have got the lepromatous spectrum. So what is happening? The tuberculoid spectrum is affected only when there is inflammatory patch over the branches of this facial nerve. So branches of the facial nerve are zygomatic. Yes, then you have got this buccal, you have mandibular, lacrimal. So all these nerves, the branches of these facial nerves, when they are affected, only then you are getting the inflammatory patch. It is usually unilateral, and even if it is occurring, it is not very, very significant. So it is not clinically significant. So that means which one is clinically significant? So if they can ask you whether the patient who is having the tuberculoid spectrum is having more risk of having the ocular complications or the lepromatous one. So it is the lepromatous which is having more risk, and even if there is involvement in the cases of tuberculoid spectrum, it is not clinically significant. So the first important thing is that it is the lepromatous spectrum which is giving you high risk for the leprosy complications. Second important thing, it is symmetrical. It is symmetrical, but it is slower than the tuberculoid patients. So these are some of the important MCQs that could be asked directly. Now let's try to see how the other areas are involved. So if I talk about the corneal invasion, they are affected by the myelinated corneal nerves, because I think this question will come in everyone's mind, that when cornea is avascular, how it is getting affected. So cornea is getting affected by the myelinated corneal nerves. What about iris and ciliary body? That is your uveal tissue. Now you always remember, I make it by the red color. This is your uveal tissue, iris, ciliary body as well as the choroid. So obviously this will be affecting by the bloodstream. And if I talk about the conjunctiva, the sclera, so again it can be affected through the bloodstream or even from the ciliary body lesions also it can spread. Okay, now this is your anatomy of the eyeball, and slowly and gradually we will see that how many of these structures are affected due to this mycobacterium leprae, both anterior as well as posterior segment, but yes, anterior segment more than the posterior segment. Now there is a long list of the eye complications of the leprosy, starting from the lids, then we have cornea, we have iritis, we have lacrimal system, sclera, ciliary body, fundus, lens, even acute and chronic iritis both are involved. So obviously you cannot remember this whole of the list, but can you see the involvement here, right? Every organ is getting affected. And I will say one thing, even if you are not able to comprehend all the things, please do remember all the lid abnormalities. They are very, very frequently asked. So you have madarosis, you have blepharochalicis, you have nodules, you have ectropion, entropion, trichiasis, leg ophthalmos, you have reduced blinking. Right? Can you see some of the things are common with the trachoma also. So that time also you can be confused with the trachoma and the Henson's disease. Then look at the cornea. In the cornea, now here I will mark you what are the important things. So one important thing is that you have to remember that it is having the thickened corneal nerves, because many a times you get this question that all of the following will cause thickened corneal nerves except. Second thing, another thing that will cause the decreased corneal sensations. Decreased corneal sensations occurs in all except. Very, very important, right? Then third important thing, we always remember that the pannus occurs in trachoma. Right, and the lid abnormalities were also occurring in trachoma, and see pannus is occurring here also. So again I am saying that keep in mind that you should not confuse it with the trachoma. Another important thing, you always remember it as a cause of interstitial keratitis. So those things that you remember it from the other things, like you remember this as a cause of interstitial keratitis, you remember it as a cause of band-shaped keratopathy. So there you can remember. And two very, very important things here is your decreased corneal sensations as well as your thickened corneal nerves. Okay, now as far as your iris is concerned, iris is the most important structure of the eye which is affected by the Henson's disease. Remember, both the acute as well as the chronic iritis is occurring. Now if it is a chronic iritis, obviously you will be having the accumulations, and you should remember the iris pearls, very, very important. Iris pearls, I will show you the appearance also, they are found in the leprosy. Then second important thing, the secondary glaucoma as well as the secondary cataract. So secondary glaucoma and secondary cataract both are occurring. So as a complication, you have to remember that both cataract as well as glaucoma can occur in these patients. Okay. Now see the lacrimal system. Now they are causing inflammation in literally every part of the eye. So they are also causing the dacrocystitis, both acute dacrocystitis, chronic dacrocystitis. Then they are also causing the inflammation in the sclera and the episclera. Uske baad they are causing the ciliary body. Ciliary body mein what will happen? There will be loss. Loss of function means hypotony. So there can be hypotony also. Now can you see, you can have the glaucoma also and you can have the hypotony also, right? So these are the most important things which will help you like anything, okay, which this will help you like anything in solving your questions. You can take a screenshot of this chart and you paste it over your wall, so that every time you are studying like interstitial keratitis, you will see yes, leprosy was there. Every time you study the band-shaped keratopathy, you can match it with it. Medurosis, ankylosis, you have you have got this ectropion, entropion, then you have got the secondary glaucoma, secondary cataract. There are so many things which are important here. Now because you know eyelids, I told you there are so many things which are found in this Henson's disease. Let's see what are they. The first important thing is your blepharochalices. Blepharo, what do you mean by blepharo? Blepharo means the eyelid. So what you are having, callus means you have loosening. So you have the loose skin folds which are present in the upper eyelids, that is called as the blepharochalices. Then you also have the nodules, because you know what happens here, the skin elasticity is lost and due to this the skin becomes loose. That is why you are having the entropion and ectropion also. So you have got the thickening of the eyelids as well as shiny nodules you can also see over the eyelids. Then the third important thing, is that in the eyelids you also have the tarsal plate. Now what happens, there is atrophy of this tarsal plate as well as the pretarsal muscles. So what happens, now the eyelids are not that effective in spreading of the tears and clearing of the cornea, and a floppy eyelid syndrome kind of a thing is found. Then you already know entropion, ectropion, you can get like bigger one nodules over the eyelid, smaller one macules can also be there. Even we can have the weakness of the eyelid movement because the muscles were also involved, and that is why there is a delay. There is a lag of ophthalmos when the patient is trying to close the eyelid. And what happens when the patient is not able to close the eyelid due to the exposure keratopathy? So I think 2 to 3 things are interconnected. We have weakness of the muscle which will be leading to the lag of ophthalmos, this will be leading to ectropion, and you know whenever there is ectropion like this, there will be epiphora. So all these are interconnected, and this will also lead to your exposure keratopathy. This will also lead to the exposure keratopathy because the patient is not able to close the eyelid properly. See, this is the typical picture of a patient who is having the Henson's disease. So it is very, very typical. So even if they are not telling you those many words, the appearance that you are getting in the image are loudly speaking, shouting for itself that I am a case of Henson's disease. Yes or no? Okay. So let's see what is blepharochalicis and dermatochalicis. Now there are two things, one is your blepharochalicis and another is your dermatochalicis. So let's see what is the basic difference between the two. So what happens, blepharochalicis and dermatochalicis mein, dermo means skin, so there is just the drooping of the eyelid which is due to the excess of the skin. If it is due to the excess of the skin which is coming out, then it is called as the dermatochalicis. Now blepharochalicis, now what is happening here, can you see this area, there is a protrusion of this fat like area through the orbital septum, this is called as your blepharochalicis. So they can be asked as a direct MCQs, these two can be asked, what is the difference, they can also give you the image, maybe along with the clinical question, they can say that the images are also given, so there you can see whether it is blepharochalicia or your dermatochalicis. Okay. Then coming to the eyelashes. Now loss of eyelashes is a common phenomenon. You will get that there will be some loss, or there may be large loss, and sometimes there is so much loss that you have very thin eyelashes, and even the eyebrows are very thin. There can be even the loss of the eyebrows from the lateral side. So you know, eye is involved, the typical appearance of the eye is also very you can say pathognomic of your diagnosis of the Henson's disease. Then the trichosis. What is trichosis? Where when you have got the inward turning of the lid margin leading to the rubbing of the eyelashes over the cornea, and due to that what can happen? I always tell you this in the trachoma also, that whenever the eyelashes will rub the cornea, corneal abrasions and therefore secondary corneal ulcers will take place. When this corneal ulcer will heal, what will happen? Corneal opacity will take place, and I think this is the most important complication like trachoma here also, because it is this opacity which can actually lead to the blindness. So basically this complication is very important. Then coming to the eyebrows. Now as I told you before also, this is very specific. You will get the thinning of the eyebrows. There can be complete loss of eyebrows, there can be even loss of the lateral half. That is very common. Next is your Meebomian gland. Now Meebomian gland is also getting atrophy. What will happen? This is a sebaceous gland. So you are not getting the sebaceous secretions. When you are not getting these oily secretions, there will be dryness. So dryness of the eye. So dryness of the eye, or a cause of dry eye, is again one of the causes is Henson's disease. So what will happen? Now if dryness will be there, what will happen? The cornea will not receive the nutrition. When cornea will not receive the nutrition, there will be problem with the corneal transparency. Yes or no? So you will get even the chronic decroadenitis. Adeno means what? Adeno means gland. So even the gland is also affected, and because gland is affected, therefore it is also a cause of keratoconjunctivitis sicca. Severe dry eye you are going to get, called as keratoconjunctivitis sicca. So it can cause the dry eye also, it can cause abrasion also. So what is this abrasion? This is superficial punctured keratitis. So that means it can be a cause of trichosis, it can be a cause of entropion, ectropion, it can be a cause of SPK, it can be a cause of corneal ulcer, it can be a cause of corneal opacity, it can also be a cause of the dry eye, it can also be a cause of KCS. Can you see this? Now coming to the nasolacrimal apparatus. Now as I told you, nasolacrimal apparatus, both acute as well as chronic decrocystitis can occur because it is affecting the nasal mucosa. So we are getting lot of bacillary infiltration in the nasal mucosa. Now whenever we have the bacillary infiltration, we will have ulceration, and whenever we have ulceration, there will be scarring. And what will happen? There will be falling of the bridge. Did you saw in that image there was a flattening of this nasal bridge, and due to this flattening of the nasal bridge there will be stagnation of the secretions, and whenever we have the stagnation of secretions, the bacterial infection are very common. So what we are going to do for that, you can do the DCR, because you know adults may you have to do the DCR only. Okay. Now coming to the conjunctiva. Now mode of infiltration in the conjunctiva, how conjunctiva will be involved in this Henson's disease, it is actually two ways. What are the two ways? One is your direct blood-borne, it can go. Okay. Now second is extension of the ciliary body, because we have got the vascular scleral channels which are present near the limbus. So they can even spread from that ciliary body, and directly also it can go. This is important. Now continuous exposure to the dust and heat will lead to the chronic conjunctivitis. So even when the patient is having Henson's disease, he can be having this chronic conjunctivitis, and due to this chronic conjunctivitis the patient will be having photophobia, lacrimation, we have redness, we have irritation. You can see even the nodule formation over the conjunctiva. This nodule will be very smooth nodule, and it will be non-tender. Now this is important because many of the cases give you nodular conjunctivitis or keratoconjunctivitis. So when they are giving you a question related to the nodular conjunctivitis and they want to answer the Henson's disease, they will write that it is a smooth, reddish, non-tender nodule, because at some places it can be tender also. Then a mild conjunctival inflammation could be there. Pterygium, even pterygium is very important. It has been found that pterygium, which is inflammatory type, which is consisting of the macrophages, and macrophages contains what? This Mycobacterium leprae has been reported. So this is a very important point. And then we have the episcleral nodules. Can you see? This is your cardinal sign. Episcleral nodules, deep conjunctival tissue involvement will be there. Alright. Now having done this, let's come to the diagnosis. Diagnosis is based on the morphological characteristics. As I told you that there are so many morphological characteristics that it is loudly speaking for itself. Okay. Lepra bacilli you can also isolate from the lacrimal fluid. Okay, and also the conjunctival scraping. So though most of the cases we have enough of the morphological characteristics, but for the supportive evidence I can take it from the lacrimal fluid as well as the conjunctival scraping. Now coming to the management. Now how to do the management, that is the primary concern. Frequent washing with the clean water. Clean means it should be sterilized water. You have to, you can boil the water and make it cool. It can be a RO water also. Then local antibiotics you have to give ample of the rest to the eye. And a very important thing, when should you refer the patient if it is not improving in 48 hours, okay? Because you know when it comes to public health, it is very important that you should know when to refer and when to not. So if you do not know that important you know demarcation, that up till what level you are giving the trial of the treatment and when it is a hard stop and you have to refer the patient. So you have to give the trial, do these steps only till 48 hours, and if you are seeing that there is no improvement, okay, then stop and refer the patient. Okay. Now we'll see the treatment according to the cause. Now if I am asking you about the cornea, You know, cornea is a very frequently affected organ in cases of the eye involvement in the Henson's disease. It is initially asymptomatic, but afterwards you can find the severe loss of vision, because initially you have SPK or you have a small abrasions, but later on you have got corneal ulcers, we have corneal opacities. So a very important thing that you are getting is the beaded appearance. I think this is the pathognomic of Henson's disease, because you know you will get the iris pearls also, there also you get a beaded appearance. So first important thing is that you are getting a beaded appearance of the nerves, and then I told you it can be causing the superficial punctate keratitis because of your dry eye, causing the punctate lesions over the cornea. Then we can have the pannus also. So this is important because till now we have read that the pannus is actually a finding of trachoma. So don't just fall upon the trachoma seeing the word pannus. Pannus actually does not mean that it can occur in trachoma. Pannus means the infiltration anywhere where you are getting the infiltration of the lymphocytes along with the vascularization. So that can occur in the cases of the leprosy also, and that is why you are getting this. Now important thing is that in cases of the trachoma where you were getting pannus, it was superiorly, but here it can extend throughout the entire circumference of the cornea. Throughout the entire circumference of the cornea we can get this pannus, while here in the trachoma it was just superior. So that is a very important thing. And finally we can have interstitial keratitis. You should remember that it is a well-known cause of interstitial keratitis. Then we can have superficial punctate keratitis on the cornea, especially on the upper part of the cornea you are getting. Now the pannus, as I already told you, it is circumcorneal in leprosy, while it is just in the upper part in cases of trachoma. And what is happening in the interstitial keratitis? Interstitial means there is involvement of the stroma without the primary involvement of the epithelium or the endothelium. So the granulomas which are occurring in the leprosy, they are infiltrating deeper and deeper into the stroma, seriously affecting the vision. And a grayish patch you are seeing due to this extension of this patch from the limbus towards the center. So this is actually your centripetal type. From the limbus it is going towards the center. So can you see, this is your first one. Let's appreciate these findings here. Can you see, this is your SPK. Yes. Then a very important thing, can you see here, pannus. So in the pannus you are seeing that here we have involvement of whole of the circular part around the cornea. This total involvement is pannus. So don't keep this in mind that pannus can only be found on the superior side. That was typically found in trachoma because upper tarsal conjunctiva and the fornix were more commonly involved first in cases of trachoma. That is why that is there. Then I told you that there can be a grayish patch that is coming from the periphery towards the center. So this is your grayish patch which is coming from the periphery and it is extending towards the center of the cornea also. And then see, this is your interstitial keratitis. This is your interstitial keratitis that you are getting. So these are the visual images that you can have in the cases of trachoma, the leprosy. Then we have the exposure keratitis, we can have the corneal ulcers. Corneal ulcer is an emergency because corneal ulcer will lead to corneal opacity and corneal opacity will lead to blindness. Do not use corticosteroids and refer immediately. Very important thing, because another important thing on which a clinical scenario can be formed. Suppose they have told you the systemic findings of leprosy, and you know it's not difficult to diagnose the case of leprosy from your systemic findings. So you have in the corner of your mind that this is leprosy, and then they start telling you about the punctate erosions. The moment they say corneal ulcer and they ask you what should be your next step of treatment, so okay, you without any double thoughts, you have to refer the case as early as possible, immediately, because this is an emergency. Second important thing, do not give corticosteroids, because you know OTC people, they are what they are doing on the first instance, they are giving the corticosteroids, so you don't have to give the corticosteroids. Okay, for the now photophobia, because you are starting with the atropine. For the corneal ulcer, they will be causing a lot of photophobia. That is again a very important problem. So what you can do, give the goggles, dark goggles to this patient. Okay, then after the corneal ulcer, there can be corneal opacity, though perforation is uncommon until and unless we have secondary bacterial infection or the viral infection, but yes, that is also a possibility, and we can also have the corneal perforation, right. Now coming to the sclera. Now though sclera is seldom affected alone, so it's very uncommon that you have Henson's disease and just in the ocular involvement you are having the involvement of sclera, but nevertheless if the scleritis is there, sclera involvement is there, the most common association is rheumatoid arthritis. Again, this is a very important point, and many of the MCQs are actually based on this information. So it can be a part of SPK, it can be a part of iritis, it can also be a part of iridocyclitis, episcleritis. So scleritis will occur in those patients who are untreated cases of like this laprometer spectrum, and usually they have the associated iridocyclitis. I told you that it is very less possibility, very unlikely that you are just getting scleritis. Mostly it is due to the untreated laprometer spectrum, and you have associated iridocyclitis. Now what you are going to get here, you will be getting localized erythema, you will be getting tenderness. Now what will be the size of the nodules? The nodules that you are getting, because you know nodular kind of scleritis will be found here. So nodular scleritis you are getting up to 5 mm in diameter, up to 5 mm in diameter you are getting this. Okay. Now episcleritis, not only scleritis, we can also have episcleritis. What is the difference? In the episcleritis, you are getting the inflammation of the Tenon's capsule which is lying over the sclera. So above the sclera, covering whole of the eyeball, we have got a capsule called as Tenon's capsule, that is called as episclera, and there we get the inflammation that is called as episcleritis, and this you can say this condition is not as severe as the scleritis. So what you are going to get, a very hard dirty yellow nodule, most commonly on the upper and outer quadrant. So again an important question, where will you find this nodule? In the upper and outer quadrant you are going to get. Sometimes this may be inflamed also. So if otherwise it is non-tender, but if there is overlying inflammation, then it can become tender, there can be tears, there can be pain, there can be discomfort, right. Now see, these are the pictures where you can see it can be having the sectoral involvement, like here we are having the nodule, it can be having the diffuse involvement also, right. And can you see here, can you see, appreciate these bluish patches? This is because it is showing that it is a case of healed scleritis. And what happens in healed scleritis? There will be ectasia of the outer coat. So you can also get the staphyloma. The staphyloma, you are going to get bulge of the outer tunic of the eyeball. You are getting the bulge of the outer tunic of the eyeball. So can you see, these pictures are, I think, very good pictures, and you can see clearly how much severe it is looking like. Okay. Now coming to the signs and symptoms. So what kind of pain and redness we are going to have? You have got deep pain, localized erythema, and you know there are usually episodic involvement. So you have regularly again and again you have episodes due to which the very important thing, the scleral thinning takes place. Due to the scleral thinning you have staphylomas. So if you remember it as a chain, we have the attacks of iridocyclitis. Due to the involvement of iridocyclitis again and again, and you are not treating the lepromatous spectrum, we can have the involvement of sclera. Now we can have scleritis, we can also have episcleritis, we can have nodular, we can have diffuse. Okay, now again and again we are having the episodes of the scleritis, episcleritis, which can lead to this scleral thinning, and the scleral thinning will actually lead to the staphyloma. So this can be a cause of the staphyloma. Okay, I'll be giving you a separate video on the staphyloma. Here we are not going in details. So what is happening, if you want to see the tenderness, now you will say that they are saying that it should be non-tender, and it becomes tender only when we are having the overlying inflammation. So that time you may ask that how to check the tenderness. So what you are doing, ask the patient to look down. Okay, and you have to palpate above here, above the tarsal plate, over and above the closed eye also. And if the patient is having pain, he will tell you. Okay, and even he does not tell you, you can see on his face. Okay, he will not allow you to palpate. It will be a tender one. So for that we will give the steroid eye drops. We can also give the systemic steroids as well as subconj we can give if we feel that they are not enough, the topical are not enough. Okay, then coming to the iris and ciliary body. Now iris and ciliary body, I think they are the most heavily infected in cases of Henson's. And which root? It is the hematogenous root. So H for heavily and H for hematogenous, iris and ciliary body. So iris and ciliary body, you can say that because it's a systemic disease, so blood spread is maximum. So blood's root is the most important root. So that means those structures are having the vascular supply are the most important structures which are involved, and they are destructed like anything. So the muscles are also affected, sphincter muscles are also getting affected, impairment of autonomous nerves is taking place. Now impairment of this autonomous nerves is actually leading to fixed and non-reactive pupil. So it also becomes a cause of the fixed as well as non-reactive pupil. Okay, now what is happening? Now when there is a destruction of the ciliary body, the function will not take place. Ciliary epithelium is destroyed. And what is the function of ciliary epithelium? The formation of aqueous humor, and therefore what will happen? A phthisis bulbi will also be taking place. Shrinkage of the globe will also be taking place. So another important thing that you are going to get is the phthisis bulbi. Alright, now we are talking about two important things. One is your nodular one, lepromata, and we have miliary lepromata, where you are getting the multiple nodules, and here miliary means multiple small tiny dots, like we have miliary tuberculosis. Now what is happening? In cases of nodular, you are getting multiple nodules, you are getting the multiple yellowish nodules of varying sizes, and where? Over the iris only. So one variety you are getting multiple nodules over the iris. In the miliary variety you are having multiple tiny white spots over the iris. So now more important is this your miliary lepromata, where you are getting multiple white tiny spots over the iris, and they are the aggregation of the bacilli only, the lepri bacilli only. And where they are found? They are found adjoining the pupillary margin. They are found adjacent to the pupillary margin, and this will help you in differentiating them from which nodules. Adjoining the pupillary margin they are found. Like in the pupillary margin, we also get the coipe nodules, if you remember, the coipe nodules, while base pe we get the Busacca nodules. These are very pathognomic, very pathognomic of the leprosy, very important. Now coming to the iridocyclitis. Now what are the types of iridocyclitis you are getting? You get the acute plastic iridocyclitis also, you get the chronic plastic also. Now what is the meaning of this word plastic? That means we will get the fibrinous exudates. When you are getting the fibrinous exudation over the iris and the ciliary body, then that is called as a plastic iridocyclitis, and this is usually precipitated when you start the therapy by the depth zone therapy. So signs and symptoms you already know, there will be pain, tenderness and photophobia. Remember the cause, it is due to the depth zone therapy. Now, if you go for the chronic plastic iridocyclitis, so obviously here the chronicity will be the hallmark. It is taking slowly, insidious onset. Chronicity is the hallmark. Keratotic precipitates in the back of the cornea and exudates. Now, because it is chronic, so here you are getting keratic precipitates, here you are also getting the hypopions, and slowly and gradually occlusio pupillae can also take place. Then you can have small and irregular pupil because of the formation of the synechiae, and finally because of this chronic plastic iridocyclitis, what are the chronic complications? You are getting cataract also, vitreous opacities, retinal detachment, we are getting atrophy of the eyeball, that is called as the phthisis bulbi. Alright. Now, if you look at the iridocyclitis per se, now a very important MCQ, iridocyclitis is the most common cause of irreversible blindness in leprosy. Direct MCQ, very important. They can ask you what is the most common cause of irreversible blindness in the patients of the leprosy. So, iridocyclitis I'll be not going into the detail because you already know iridocyclitis is iritis and cyclitis means ciliary body inflammation. So, you will be getting the combination, and we already know that iritis we are not getting in solely solitary finding in most of the cases, and here also we are not getting iritis. If I am getting the involvement of iris, I am also getting the involvement of ciliary body. So if the question says only iritis, don't think about the Henson's. It is never existing in the isolation. Okay, iris and ciliary body. A very important thing is that it is silent, no redness, minimum ocular discomfort. So, blindness will be resulting if the diagnosis is mixed, and you will get the diagnosis only when you have corneal ulcer, because even corneal abrasions are also painless. So, this is very important, that though iridocyclitis is the most common cause of irreversible blindness, but it is very silent. So, you have to search for it, you have to have the high degree of suspicion for getting this. Okay. Now, the iris pearls, as I told you, iris pearls is very important here. What are the iris pearls? They are very small, round, white color, shiny, because they are showing you the collections of the bacilli, and where they are found, it is the first sign of the pupillary invasion, first sign, and usually they are getting infiltrated due to the blood. So, they are coming through the blood, they are accumulating, and as they say that they are actually hiding from the treatment, they go into the iris and they hide there. So, they are highly vascular, and because they are highly vascular, the chances of infection are again very high here. So, if you look at the iris pearls, the typical appearance of the iris pearls is like this. So, in order to rationalize the word iris pearls, see, they have also given you the pearls here, and you can simulate the appearance of these nodules, small fine dots, whitish dots which are present on the iris here. They are very similar to the pearl necklace. That is why they are called as the iris pearls. So don't confuse them with the brush field spots which are found in the Down syndrome, with the Lish nodules which are the iris hematomas present in neurofibromatosis. You have Brusaka nodules which are found at the base of the iris or the mid periphery. You have got the Koipe nodules which are present at the pupillary border. So can you see there are so many things which are coming in the DD of these iris pearls. Now due to these iris nodules and infiltration of the iris through the blood, eventually we can have iris atrophy. So what will happen? There will be change in the structure of the iris. What is the typical structure of the iris? It is called as the collarate pattern. The typical structure of the iris is called as the collarate pattern. So the crypts that are present in the iris, they will get flattened, there will be thinning of the stroma also, and what will happen? Therefore the deeper pigmented layer of the iris will now become visible. Even the holes like sponge, have you seen the sponge? You can see the holes there. So you can even see the holes coming out because there is a atrophy of the stroma, or you can say pockets are formed. And the pupil, because it is a case of iridocyclitis, so obviously the pupil becomes pinpoint here. Now because the pupil is very small, pinpoint, this person will typically behave as the night blind. So can you see, we can use the word night blind also in cases of Henson's disease. Now if we come to the posterior segment, we have the involvement of the choroid and the retina and the pearl-like lesions that you were getting in the iris. Similar lesions we are getting in the posterior segment like choroid and retina, but it is very rare. Okay. Now the lacrimal drainage disorders. So because you have many problems with the eyelids and the muscle contracting power is also decreased, so basically the tone is decreasing, there drainage is also poor, blinking is not taking place, ectropion, entropion is taking place, exposure keratopathy. So a very important thing is epiphora. So when we are analyzing or evaluating a case of epiphora, one of the causes there can be the Henson's disease. Now coming to the nerve involvement. So you have to remember the two nerves involvement are again very important, especially in the lepromatous spectrum, that is both your fifth nerve as well as the seventh nerve. Fifth nerve as well as seventh cranial nerve, usually you get bilateral involvement, but rare is that you get the total paralysis. We are not getting the total paralysis, so two nerve involvement is again important. Now two nerves involvement, where do you find? In the viral keratitis also we have neurotrophic and we have neuroparalytic. So here also you can get involvement of both the fifth nerve as well as seventh nerve. So when there is involvement of the trigeminal nerve, okay, ophthalmic, so if you look at the ophthalmic division of the trigeminal nerve, what are the things that are going to be affected? You have involvement of cornea, also conjunctiva as well as adnexa, because it is a sensory division of the eyeball. We will have loss of sensations. Okay, so normal blinking is about 16 to 20 per minute. So you will have severe loss of blinking. You will have the loss of corneal sensations. And how will you check the corneal sensations? With the help of the anesthesiometer. Corneal Wick test is also there. This is the instrument, anesthesiometer, or we can check by corneal Wick test. So what you do for the corneal Wick test, we can make a wick from the cotton, okay, ask the patient to look straight, okay, bring this wick, that should be very thin pointed tip, and bring it from side. If you bring it from the front, the patient will squeeze the eye, okay. So you have to come it from the lateral side and very slightly, slowly try to touch the cornea and see what is the patient's response. So this is how you check the corneal sensations. Absence of the blinking will lead to obviously the abrasions, and there will be ulcer. So this can also lead to the exposure keratitis. Yes, exposure keratopathy or the exposure keratitis is same. Then we have the involvement of the facial nerve. Now facial nerve is your motor nerve, due to which we have the leg of thalamus, we have got the sagging of the lower eyelid, we have got ectropion. So this ectropion is taking place due to which nerve involvement? Due to the zygomatic and the temporal branch of the facial nerve, which is giving the supply to the orbicularis oculi muscle, which helps in the closure of the eyelid. So that is getting affected, due to which the patient is not able to close the eye. Okay, then we have got the other things, that is incomplete drainage is also taking place, because you know the marginal fibers of the orbicularis oculi will also help in clearing away the secretion. So because these are also involved, there will be inadequate drainage, and finally we have the epiphora. So epiphora is also one of the important things that you are going to get in the patients of the ocular involvement of the leprosy. Now coming to the eye examination. How to examine the eye in this case? Now always remember that all eye problems may not be due to leprosy. There can be coincidental findings which are along with the findings of the leprosy involvement. So don't try to confuse your diagnosis, because you know the age group where it is found, you have lot many problems by itself also. So one is your spontaneous blinking. You have to see how much the patient is blinking. Pain stimulates blinking, and you have to also see the symmetry of blinking. What is the amount of blinking present in an eye, whether it is stimulated blinking or it is spontaneous blinking, whether it is complete or not. Ask the patient to close the eyes as if he is sleeping. We will check the orbicularis oculi. Then look for the leg of thalamus. Look, he is able to close the eyelids or not. Look for the epiphora. Look for any exposure keratitis. Yes, look for the pupillary response. See the size of the pupil also, whether it is fixed, whether it is dilated, whether it is reactive or not. Look for any nodule. If nodule is there, then you have to look for the tenderness. Check the visual acuity. Look at the eyelids, whether you have entropion, ectropion, or you have got any calluses, blepharochalasis, dermatocalasis, if you have any trichiasis, and you also look for the IOP, because secondary glaucoma can also take place. Then also check the visual acuity. If the person cannot read the top line, even the topmost letter, or is not able to count the fingers, they are severely visually impaired and have grade 2 disability in the eyes. Then we say that it is the grade 2 disability in the eye. Now, an important question: when should you refer? So when should you refer this patient? Leg of thalamus having the large lid gaps, when it is more than 6 mm, it is the time to refer the patient. Or you have the acute red eye and you are fearing about scleritis, episcleritis, when you know that this patient requires surgery for trichiasis, for entropion, for ectropion, that means the lid deformities if it is there. Then if the patient's vision is very less, visual acuity is less than 6/60, you have to refer. And then patient has developed the cataract, because anyhow cataract will require the cataract surgery. Now the important things about the self-care. What are the principles of the eye care? So in order to protect your eyes, first of all, always protect the eyes from the dryness, from the dust, from the smoke, from the sun. Yes, from any irritants. Detection of the signs of the irritation or any injury in the early stages only. Okay, take every single symptom that you are having in the eye very carefully. Detection of the signs of involvement also of the any ocular adnexa, that is again very important. Now how? It is easy to say, but how will you prevent it? So how can you protect the eyes from the dryness, from the sun, from the dust? Use more and more of sunglasses with the side pieces also, because what happens when we are using the sunglasses, you are protecting it from the front side, but the sides are empty. So use these side ones also. These are your side pieces. So it's a good idea to use the sunglasses or the dark goggles which are having these side pieces, or use a hat with a broad rim. Then eye shields you can use at night. Never apply a bandage, because you know, if you are applying the bandage, the cornea is already insensitive, so you can hamper it more and patient will not tell you anything, he is not feeling any sensations. Then try to blink more. This is called as think blink. Means deliberately you have to blink more, so that you are doing effective clearance of your drainage. Keeping the eyes moist, keeping the eyes clean, wash them frequently, okay. And if normal facial muscles to push their cheeks up and to close their eyes. So we can try closing our eyelids, so that we are checking the facial muscles whether they are working or not, and keep them eyelids clean. Then blink frequently. You have to blink also. Try to wear hats when you are going out, sunshades with the proper sunshines. Early detection of the signs of irritation, injury or the involvement of the ocular tissue. So if the patient is already having the Henson's disease, you have to do daily inspection for any redness of the eye, any corneal injury, any sign of abrasion you are getting, any kind of tenderness on touching the eye. And very important, you have to teach the person, because every time you may not be there, so you have to teach the person to inspect his own eyes with the clean hands, okay. Local hygiene is again very important. Always wash your hands, not only with the water, maybe with the soap also. Use a mirror to see if there is any area of tenderness, any area of redness, if there is any irritation. And he has to, even he can appellate any eyelash if he thinks that sees in the mirror it's going inside and it's irritating, or go to the ophthalmologist at the earliest. And to develop a habit to observe a few selected objects placed at distance. Why? Because this will help him for the detecting the early deterioration of the vision loss. Because what happens when there is a vision loss, it is actually the distance vision which is deteriorating. So when we are doing our day-to-day activities, we do not come to know actually that actually vision is getting affected. So when you make a daily practice, that daily I will look at that that poster, or try to read this, or try to approach some distant object, so it will come into the notice very early that the patient is having the deterioration in the distance vision. So this was the elaborative ocular complications and the involvement that can take place in the Henson's disease. In case of any query, you can always ping me up at any of the social media platforms. If you like the video, please hit the like button. This will help me in motivating me and making more such informative videos for all you guys. And also do share the video with those people whom you think will definitely benefit from this video. Give me suggestions what all other topics you want me to make the videos on, so that I can help you in this COVID times. I want to help you in the maximum possible manner, so that show must go on and your academics and your preparation does not suffer at all. You can visit my Facebook page and Facebook group also. Lot of academic and motivational stuff is there, and do join us on Telegram group and channel for the daily quizzes and the other academic posts. Thank you and happy ophthalmology.